Hi. Thank you. Yes, I'm just a humble Jungian analyst, not a doctor. And I'm not really terribly technological. So when I press that, it's going to move to the next slide. Okay, I'll gamble it all works. Thanks to Dr. Levine. That was great to hear about the family perspective. And I'm glad that as well as the family perspective, we're also going to hear later about the social perspective, because I think it's incredibly important. You know, trying to bring children up in this social context, it's really difficult. Some of the problems we're facing are massive evolutionary problems, I think, about trying to adapt to huge changes in society, including pressure on nuclear families to create an environment in which children grow up able to love and work, as Stephen says. You know, it's difficult. So although I'm going to talk about the individual, I'm also very aware that there's this other social and familial dimension. So we're facing collective problems, actually also made worse in some ways by the lockdown, because we're very social people, and I think trying to bring up kids within a nuclear family puts huge pressure on the individual parents, especially if the relationship then breaks. So people shouldn't blame themselves if things go wrong. It's just that when the distress gets expressed in this kind of terms, it can lead to horrific results in terms of the changes in the body. And my work with detransitioners very early on showed me how important it is to work psychologically before people make permanent changes to their bodies that they could come to regret. So my talk today is going to be trying to outline to a certain extent how we might understand gender dysphoria, possibly trans identification, psychologically, using, I suppose, a mixture of psychoanalytic concepts, particularly dissociation, how we might work with those individuals who come to see us because they present particular problems. So how do we work? Do we have to adapt our way of working as psychotherapists or psychodynamic counselors or other psychological workers? But the other question that I'm going to try and cover, which I think is a bit more important socially, is because we've got the WPATH conference going on over the road, I want to address the question of experts by lived experience, because I think a lot of the people over there are experts by the lived experience of being trans. But what does that mean? You know, is a middle-aged trans-identified male who's brought up children and gets off on the WPATH UNIC archive BDSM pornographic website linked to the WPATH, is that person really an expert on a young woman trying to grow up through her adolescence, who's terrified of her body, her emerging sexuality, wants to take puberty blockers to stop all that sexuality developing, maybe autistic, and maybe also frightened that she's getting feelings towards other girls. So, you know, the homophobia that she maybe faces when she's growing up in an environment that doesn't really accept that. So I'm also going to address the question of lived experience, right? And it all comes under this umbrella. You know, the person presents as having a problem with their body, and then you're trying to get them into therapy. So how the hell can you do that with these people? So there's a history to this. The history of medicine is full of psychological effects that are misattributed to physical factors. This is a diagram, it's a painting from Franz Mesmer's consulting room. I think it was Andrew Gold was talking yesterday about exorcisms in South America. And in Europe as well, we were exorcising quite religiously until fairly recently. In fact, Foucault writes about the change around 1800 of the birth of the clinic, when suddenly we started beginning to think about medicine scientifically. And Franz Mesmer was one of these people who thought that you could cure people by connecting them up to a bath full of magnetic iron filings, glass beads and water that had been magnetized. And this is one of his evenings where high-class people who we would think of as hysterical would come for his new scientific treatment, his new mesmeric treatment, and then rather like people who were being possessed and exorcised, they would then fall about shaking and convulsing and then declare themselves cured. And it was all put down to this, this effect of magnetism. Quite some people who will be familiar with this already, but I'm just wondering if you ask one of those people who'd been to those evenings what their experience was, they would be probably telling you as an expert by lived experience about the powers of magnetic healing. And of course, they went on to try and test whether this actually worked by giving people a series of objects, some of which had been magnetized and others of which hadn't actually been magnetized. And they found that people had the same reaction so long as they thought that they were touching something that had been magnetized as they did when they really did. So that was the first placebo trial, really. And it just, I think experts by experience, by lived experience, are really important, because in psychoanalysis, we work on a case-by-case basis. We don't do huge meta-analyses of data. We try and understand individual people. So we need to value lived experience, but we also need to understand that sometimes subjective experiences can be mistaken. And we need to bear that in mind. Out of mesmerism, developed Charcot's approach to hypnosis. We now think of it as a psychological intervention, and that people in a certain social situation under suggestion tend to do what's expected of them, including falling down, convulsing, getting cured, and so on and so forth. And actually, out of mesmerism developed hypnosis, and Freud actually studied hypnosis, of course, with Charcot. And so out of, well, ultimately, animal magnetism comes psychoanalysis, because Freud gave up hypnosis to practice as an analyst. Anyway, basically what seems to happen, if you, I'm going to skip a little bit through the history of medicine, because I think once people start to think psychologically, and then there tends to be an explanation for instance, Charcot's physical explanation for hysteria. He had an explanation for hysteria, which was a physical explanation, which once Freud began to analyze the meaning of the symptoms in hysteria, it changed people's social and emotional attitude towards hysteria. So it stopped being a popular diagnosis once it was thought of as not a physical thing, but something that could be understood psychologically. And I think the same is going to happen in terms of trying to understand trans-identification and gender dysphoria psychologically. You know, the trouble is people then think, well, you're saying it's not real, it's imaginary, or you're saying I'm to blame. And there isn't really this concept that we can, well, the unconscious mind. So what we're trying to face, I think, in our society and culture as a whole, is that there are things which we intend, but we're not consciously intending, or there's things that we know, but we don't consciously know. And they affect us sometimes in the most bizarre ways, which we experience as being malfunctions of our body, but they may not be. And then we think of them as having a physical treatment and a physical explanation. But actually, what we need to do is try and understand that sometimes, not always, these things actually are carriers of a psychological or emotional meaning. And that's where ordinary orthodox psychotherapy comes in. It's not very different for trans-identified kids than it is for anybody else, frankly, except that you're dealing with people who have pushed the meaning and the unconscious knowledge so far from the conscious disembodied self that there's a huge resistance to trying to get that back into conscious awareness. So you're trying to cope with somebody who's tried themselves to cope with an experience which is so frightening that they've had to push it away and sort of encapsulate it within the body and then try and get rid of it by changing the body. So I'm trying to say that there's a history of medicine here where things like multiple idiopathic physical symptoms, medically unexplained physical symptoms, MUPS, MIPS, and now we call them MUS, medically unexplained symptoms. In some ways, these are all cultural attempts to escape the stigmatization of the psychological associations to hysteria and psychosomatics. So once you describe something in Freud's way using a psychological explanation, there's a resistance, the term gets dropped, and then we look for another way culturally of understanding and defining the thing that the person's suffering from. Arguably, the huge upsurge in diagnoses of ASC, ADHD, although there may be physiological components, particularly to the extreme end of it, they're probably doing the same thing. You know, they're giving you a physical explanation without any actual underlying certain medical diagnosis of something which I think can probably be fruitfully understood, at least in part, as a reaction to both unconscious things which we don't want to know in ourselves, and also those things are a kind of reaction in the individual to things that as a society we haven't really sorted out or found ways of working with. I mean, I think I was talking to Bettina earlier about the idea that we are in a cultural place where for hundreds of thousands of years we lived in small communities where we all knew each other, we were hunter-gatherers, and it's only in the last 5,000–10,000 years that we've settled down through agriculture into these big cities, and we've tried to create a life where we can be happy and where we can live and work and we can function, but we're struggling because we've done very well materially, but psychologically or emotionally we've fucked up, basically. So there isn't a better way of putting it. Okay, so what I'm arguing then is that gender dysphoria and transgender identification, that they are the latest manifestation, or a reasonably new manifestation of one of these fads, which hopefully will pass, but dangerous because of the treatment. So quoting from a paper I wrote in 2018 called The View from the Consulting Room in the book Transgender Children and Young People. So unlike intersex states, there's no credible evidence of a physical component to gender dysphoria. In contrast, several psychological factors may help us understand it. So closing a discussion of these factors down to protect trans people from stigmatization seems a bit like deliberately throwing the compass overboard when we have no other way of navigating, because there's no physical explanation, you know. So what might it be, psychologically speaking? So I'm going to argue that it can be understood fairly simply using classic psychoanalytic thinking as a dissociation between the mind and the body, so a dissociation of mind from body, excuse me, and B, a dissociation of the male from the female elements in the psyche. So what do I mean by that? I'm going to very quickly, briefly describe a case of mind-body dissociation. So before I trained to be an analyst, I used to practice as a complementary therapist. Don't all attack me, you know, I did some research into homeopathy and I discovered it was probably working for psychological reasons, and then I retrained and became an analyst. But before I did that, I noticed in my cases some things which I can use both to illustrate mind-body dissociation and also this idea of the expert by lived experience. So Anna came into my consulting room 2.5 years old. She was suffering from recurrent lung problems, which the doctor kept repeatedly treating with antibiotics. She couldn't, she got better for a bit, and then she got worse again. And the doctor said, well, the best thing might be to prescribe asthma medication for her. Would you like an inhaler? And the mum said, no, I'm going to take her to see Bob Withers, the homeopath, because that might, if that works, that's going to be better for her than lifelong medication on asthma treatment. And as we were talking, Anna fell off my couch. I wasn't really equipped for children at the time. I had no toys or anything like that. But before I could notice what had happened, the mum had leapt up out of her chair, picked Anna up in an instant, had her back on her seat, and was talking to me as if nothing had happened. I thought, good God, you know. And I said to the mum, does Anna cry much at home, you know? She said, no, she never cries. Proudly, she said, she never cries, never cries. Now, at this time, I was reading a book called Psychosomatic Medicine by a classic psychoanalyst who's called Franz Alexander, and he talked about the psychological components in asthma. And he happened to say that suppression of tears is a factor, that you don't want to let out your tears, so you don't breathe out. You hold your tears and your sadness and your grief in. And so I gave this homeopathic medicine prescribed according to the principles of homeopathy. And I said to the mum, by the way, if Anna starts crying after taking the medication, don't panic, it'll be a good sign. So the mother came back 3 sessions later. Anna was cured, miracle cure. But I discovered what had been going on was that the mother herself, when she was born, had been born to a mother with a mysterious lung complaint. And the mother had been completely isolated from my patient as a baby. She was just behind a glass screen in the hospital because the doctors thought it might be infectious. And so what I hypothesized, and over the time working with the mother now, what I worked out was that every time Anna did something which might make her cry and wanted the comfort of the mother had reacted with a panic because she sort of unconsciously remembered what it was like to be a baby that hasn't got the comfort of a mother to pick her up and put her in her arms. And in order to preserve Anna from that discomfort, the mother, let's call her Sarah, would do anything to spare her child from the same trauma that she'd been through, that she didn't want to remember, but she did unconsciously remember. So it's this idea of an unconscious memory of something that you want to protect yourself, the other person from. And then I think what happened was that Anna picked up the mother's dysregulation. Her mother's anxiety was something she could feel, and she thought, okay, if I cry, Mum dysregulates and I lose her as a reliable, consistent presence. But if I stop my crying, if I dissociate from my wish to cry, if I cut off from my body and my pain in my body and my wish to cry, and I identify with something disembodied, then I can keep some sort of connection going with Mum. So very early on, I think she learned to inhibit her crying for that sort of reason. So I'm using this as an example of mind-body dissociation, because I think this happens to all of us. It happens to me when I don't sleep, and blah, blah, blah. We all dissociate. But also because if you asked Anna or Anna's mother what her lived experience of homeopathy was, I think they would say, oh, well, it's great, it really works, doesn't it? Just like the trans people say, yeah, this is great, I really benefited from my medical transition, but it might not be the actual physical treatment of the transition any more than it was of the homeopathic remedy or of the magnetic healing that actually creates the cure. So be careful about lived experience. How am I doing, by the way? How much? Oh, so is it? Okay, 13 minutes. Okay, that's going fine. Amazing. Now, yeah, okay. Yeah, it's a good way of getting back into the body breathing, isn't it? It really is, yeah. And the other thing which I was amazed to discover was Winnicott, as early as 1966, was working with a man who, on his couch, started talking about penis envy. And Winnicott said, but I'm listening to a man talking about penis envy. This is weird. What's going on? And then he had this sudden fantasy that he was actually talking to a little girl. And he shared it with the patient. And the patient said, oh, my God. Thank God you've said that. I've been in analysis with a number of people for 14 years. I've never been able to leave, and this is why. I feel like I'm a little girl, and nobody's really recognized that. And I'm so glad you've said it, because if I said it, people would think I was mad. Now, this man was way back in the early 60s, before trans identity gave him a chance to explain how he felt. So I think he would have been diagnosed as being trans today, but he wasn't at the time. Anyway, what Winnicott said was, it's not you that's the mad person, it's me. Because I know I'm seeing a man, but I've got the fantasy that I'm talking to a girl. And Winnicott then realized that what had happened was that he was unconsciously identifying, to use a technical term, in the countertransference. That is, he was feeling the same as the patient's mother, because he felt the mother, just like Anna's mother hadn't been able to allow Anna to cry, this patient's mother hadn't been able to allow him to be a boy without dysregulating. And they had enough material in the analysis to recognize that this child growing up, in order to maintain an attachment to mother, had to identify with a disembodied female side of himself and to dissociate from the male part. So Winnicott then enters an analysis where he's trying to talk both to the male side and the female side, but instead of integrating together and connecting creatively, they're fighting each other, trying to kill each other. And so there's this huge dissociation. So this is the two factors I want to say. Everybody's individual, we're all individual, and you can't generalize about trans, but I think this can be a useful way of understanding what happens in a significant proportion of trans people. Okay. So I've already said this, but I'll run through it very quickly again. Experts by lived experience. Yeah, the question at the end is the important one. If I've helped establish that we need to value lived experience, but at the same time, if we take people too much at their word and we don't interrogate it, we can be misled, then does it matter? If a treatment makes a person feel better, does it matter? And if it does matter, why does it matter? You know, we had the same question yesterday from Andrew Gold, which is, does it matter if people feel better after they've been exorcised? Does it matter? If people feel better from homeopathy, does it matter? If people feel better from medical transition, does it matter? If these things are actually working for not specific reasons to do with the treatment, but for psychosocial, emotional factors. I'd argue that looking at the degree of damage done by the treatment is an important factor in answering this question, does it matter? But I'm going to leave some questions, time for questions at the end. Did I say that one of the reasons that this experience of experts from experience is important is, for instance, the British Medical Association in England at the moment are trying to decide whether they are going to support or not support the CAS review. And the person in charge of that, I think he's called David Strain. He's a geriatrician, you know, looks after old people. But his first port of call is going to be consulting experts with lived experience. So the question is, when he asks these experts by lived experience what approach the BMA should take to the CAS review, the question is, which experts by lived experience is he going to listen to? Will it be the middle-aged men that WPATH support, or will it be the detransitioners? So I think I do need to say that about my experts by lived experience page. Sorry if I'm repeating myself. Now, to get on to the developmental and trauma-informed therapy, which is the sort of ordinary psychotherapeutic approach that I'm advocating, really, that dissociation is a natural reaction to trauma, including early attachment trauma and deficit, which we've all got, or we've all suffered from that to varying degrees. But undoing that dissociation requires re-experiencing the trauma and the deficit of the dysregulated, either re-experiencing the trauma and or the deficit and the dysregulated affects associated with that trauma, usually in the company of a containing other. So, for instance, I wrote a paper about this way back in 2015 called The Seventh Penis, which is now banned because of objections using the idea of confidentiality from one of the patients who recognized themselves in an account of an interaction between myself and him. So I can't talk about that here without risking, you know, being further penalized. But there was a paper which got published just yesterday, by Roberto D'Angelo, that some of you will know of, and it was called Do We Want to Know? And in it, Roberto describes a repetition in the transference and countertransference, that is, in the relationship between him and his patient, of a really dysregulated traumatic part of the patient's past. So the patient, after 18 months of working with Roberto, so twice a week, finally admitted that these idealized parents that he'd been living with and talking about and working with, actually he remembered an incident where his mother, for reasons that he couldn't really understand, lost it with him and would attack and physically assault him as a child repeatedly. And then the patient actually said to Roberto, at a slightly later session, when Roberto was inquiring about the gender identity and the origin of the gender identity, the patient said, "You've got to be very careful here. You need to be you're in danger of overstepping the line." And Roberto suddenly felt very attacked and in danger of being complained about, because they can, you know, a patient can use this idea of conversion therapy, transphobia, to attack a therapist with. And what Roberto doesn't say in the article, but is implied through the description, is that this is a kind of repetition in the transference, countertransference of this unregulated experience which the patient had had as a child with his mum. And it was an opportunity. So the patient, who was a male patient who identified as female, was unconsciously identifying with the mother who had attacked him, and he was then using transphobia and conversion therapy as a weapon to attack Roberto with. So Roberto was put in the position of feeling like the attacked child who is very frightened and very vulnerable, and who the patient wanted to get away from. He said if he was identifying with this vulnerable boy and dressing up as a girl and just being gender fluid and expressing himself in a free way, he'd just feel like a pathetic faggot. And so what that ordinary interaction, although it's very difficult, it gives a chance for the therapist and the patient to work through these earlier traumas which weren't actually managed in relation to the original experience with the mother. And that's just ordinary psychotherapy. It's very difficult, and the therapy can break off. You can lose the therapeutic relationship. And just finally, I think the people who have a theoretical way of understanding this is Jung, who talks about the drive to individuate. That's the drive within us all to become whole. There's a part of us that wants to integrate the split-off, dissociated parts of our experience. There's a part which brings back dreams, which brings back experiences, which recreates. It's the repetition compulsion. The thing that we need to try and deal with comes back to us, and then there's a chance for us to consciously integrate it rather than dissociate from it and push it into the body and then try and cut it away by altering the body. And Winnicott's idea that there is a true self, that if we set up a false self where we've dissociated from the body and we've dissociated from our difficult experiences, there is also, according to Winnicott, a part of us which wants to reintegrate that split-off experience. But again, when we try and get back into the body to feel it, we encounter the original experience which caused us to dissociate in the first place, and that then can create great resistance. But it's there in Winnicott, where what he thought was experiences like the one that I described with Roberto, where the trauma is repeated in the here and now in the room. It sort of detoxifies the experience, it makes it safe, it means people can talk about it, think about it, manage it, regulate the feelings associated with it, and then disinvest from the idea of dissociating from it by cutting off the offending body part associated with it. So that is my talk, and this is my final image, which is supposed to evoke a kind of, I don't know, both yes.
We have a question over here. Would you like to stand and introduce yourself?
Thank you.
Hi, my name is Rafael. I'm Brazilian, also political scientist, and I wrote a book. The name is Gender Ideology, the Delusion of Wrong Body. So one of the points that I studied is about the anthropology of this, about everything what's going on. You mentioned Franz Anton Mesmer. But one thing that I realized is Mesmer was foundation for Jean-Paul Charcot in France, and also for Alfred Adler in USA, and later Freud. After Freud, Edward Bernays, the father of propaganda. But what I have seen is the foundation of everything is the mass manipulation, because, example, Edward Bernays was responsible for the freedom of women in USA, motivated them to use cigarettes. And the same standard goal is applied today for motivate kids to hormonize themselves. Don't you think we are use the same pattern of Edward Bernays, Freud, Jean-Paul Charcot, and later sorry, I messed myself. What I want to say, they are using mass manipulation to introduce those ideologies in the society. Example, we start wrong, and we are going wrong. Example, for me, Freud was they learned how to manipulate through his relative. Edward Bernays was his relative. He was uncle of Edward Bernays. But what I ever seen again is the same pattern before is applied today.
Yeah, I think thank you. I think I understand what you're saying, and yeah, I mean, what I'm trying to argue against is, yeah, I'm trying to say that in some ways being trans is not exceptional. You know, we've seen this story before. We've seen similar stories, and a lot of the time, people who are trans or suffering from gender dysphoria, they want to be seen as a special case, so everybody has to change their way of thinking and their way of working, and I don't think that's necessarily true. And I think that if you look at somebody like Mesmer and all of these people falling around into their hypnotic trances and convulsing and getting better, yeah, the question would be, is that a mass manipulation where people are deliberately creating a group of patients or a group of followers or a group of customers for big business, for big pharma? Or is it, you know, those people themselves, I'm trying to argue, if you asked them what was going on, they wouldn't say, well, I'm trying to fit in with Mesmer because, you know, I really like him, and so he wants me to fall about and convulse and foam at the mouth and then feel better. I think people unconsciously pick up cues from one another all the time, and so they don't realize why they're doing what they're doing. So I think if you look at it from the subjective point of view of the patient, they have a genuine lived experience which they authentically want to convey. That doesn't mean that there aren't also bad actors and people, for instance, wanting to exploit that. So I'm sure that the algorithms that we get on YouTube encourage kids to watch all sorts of transitioners videos which say how wonderful the drugs are, and I'm sure there are people making money out of that sort of manipulation. But I think it's a mixture of unconscious factors in the subject, which you know, may be acted in good faith, and also other people acting in bad faith. I'm not a huge conspiracy theorist. I do think that if we illuminate this, there is a chance to turn it round. You know, we do have a chance to make things better, I think. And I don't see it as a battle between good and evil or clever people who are outside controlling and manipulating all of us. I'm not saying you're saying that, but I think there's a danger of both sides becoming a bit paranoid about each other and not actually being able to empathize with each other. And if you can't empathize with your enemy or with the other side, you can't negotiate. And if you can't negotiate, you can't live in peace. And if you can't live in peace, you can't work and you can't love. So, you know.